Hello and welcome. I'm not sure if everyone can hear me at the moment, and hopefully people can hear this quite well and can hear the voice, and they're also seeing the title of the webinar. Let me just make sure that we're recording properly, and we'll see if anyone else is here. If anyone isn't hearing the webinar, please let me know via chat. Okay, so today we're going to be looking at what are the healing limits of Bowen Therapy. And I'm not sure if you can see me there, but if possible, if nobody's seeing me, let me know by text, and I'll jump on it right away and see if we can get a better picture. So welcome, I'm Jonathan Damonte, and I'll be your host for this webinar. The title of the webinar is what are the healing benefits, or the limits, what are the healing limits of Bowen Therapy? And let's have a look at it here. So today's webinar topics will cover a couple of cases. One, a case of severe hip injury, and the second, a lifelong scoliosis. So they should be quite interesting for us. But first and foremost, I wanted to start with a discussion about how to get the most out of your Bowen Therapy visits, especially in the early visits when you have the trust of a client and they're there and they're willing to try this. They've arrived at your office or clinic, and you've got a chance to really do something very important for them. And one of the pieces of advice I would recommend to most people is not to overthink what you're doing, and having a level of trust in the technique is a very important part of your ability to help clients and aid their recovery. You know, you are simply a conduit that's opening up their body to work better. And you can only see what you can see. So whether you're working with a lot of years of experience or you're just coming to this as a new practitioner, you don't have to work overtime in your processes. Just do the job at hand. And the second tip I wanted to offer was where I write, don't underwork the issue they've come for you to treat. And that means that if they've come with a variety of problems, chances are you're going to be able to address some or all of them, even on the first visit. And that, as you know, can depend on how well they might respond to the treatment or how badly they might respond to the treatment. For example, today I had a case of a severe back spasm come in the sacral iliac joint on the right side. It had been only a week of duration of this injury to their back. It is a chronic problem. They've had an experience of it about 25 years earlier. And they came in a lot of discomfort, a lot of misalignment. They're bent over to the side, accommodating this injury. I did have them lay on the table on their tummy, and I did my normal procedure. I did 3 procedures on the back, and they included BRM 1 and 2 and a procedure called sacral release. So after about 35 minutes, they turned over. And it's at that point that all hell broke loose. They went into an acute spasm of this low back injury. And it took a lot of effort to reduce it, to get them to the point of being able to lay down again, and this time on their side. And I rescued the, so I'm just going to return a text. Someone wrote that they can't see me, and I'm just going to ask them if they can hear if they can read the screen. Okay, hopefully that's the case. All right, so what we did, we had them walk around a little bit and drink some water. They cried, actually, quite loudly, and it was very scary for them. It was very scary for everyone in the clinic. And the explanation I gave the patient was that the inflammation that was guarding her back problem was removed from the treatment. And that, in addition to laying down for a long time in one position, had caused the spasm to occur when they turned over. And so we got them up, walked a little bit, and then laid them down again on their side. And in that position, I did BRM 1, moves 1 to 4, and waited about 5 minutes, and the spasm abated. They were able to stand up, and they had much better posture, and what can I say? They were able to receive the last procedure, which was really the most important, which was the standing sacrum procedure. So that got them into a posture that was correct. They were still smarting a little bit in their low back, and that was a real saving grace for them. So, you know, there could have been the situation where I chose to do less and had only done BRM1, BRM2, and hadn't done the sacral release. And it's hard to know whether they would have been better when they got to turn over than they were in this case, where I had done the sacrum release too. So it's possible I did too much, but all worked out in the end. And I think the explanation was true, that everything was so relaxed that the problem was more exposed, and it just took a lot more time for it to recover as they turned over. So then that brings up the third point, which is don't overwork the area or issue that they've come for you to treat. And so this is a very delicate line, and I always go by a measure that many of you might have heard me state in the past, where I'll state that it's better to do less when the client has a very big story or a long history of problems. In a situation like that, do less. And when you're concerned about how they might react. Now, in the case today, for example, I had no way of knowing that that would be an aggravation that would occur. And I still think it worked out very well. The client left with much better posture, and I'm sure by tomorrow around midday, they'll feel a lot different than they did this morning. Another thing that I've wanted to talk about in some of these webinars are actually about the basic Bowen therapy move. And with most practitioners, there's a large range of pressures that practitioners will apply in doing the procedures. And that's something that comes about from the different instructors that have taught the procedures to students. And I feel that a lot of practitioners are actually very light in their touch. Not that it's light pressure that is wrong. You can be very gentle with the procedure. But my idea is to encourage you to have enough challenge of the structure you're working on so that it engages a kind of tension, whether strong or light, doesn't matter, but that it has a kind of challenge that's put into the structure. So that when you make the move, there's a release of that challenge. And so I'm going to show a little video of the procedure, and I'll use this one here. And in this procedure, let's take the volume off so you can hear my voice but not the video voice. I'm just going to demonstrate BRM 1 moves 1, and we'll see that there's an amount of palpation taking place over the muscle. This is just above in the waist of the client. Here you'll see secure fingers. The thumbs are square, and there's a kind of goalpost shape to that alignment of thumbs and fingers. Slack, enough slack. You can see how gentle that slack taking is. Now a depth adjacent to the structure you're challenging. And then using your body weight, you can push through to release the structure you're working on. So really kind of simple. And the same thing would go for the opposite side. I'll just rewind that a little bit and let's have a look at that one more time, where you see skin slack, depth, challenge, and a move. So this is going to vary dramatically from client to client, and there'll be several. I just got a text that you can't see the video, so let me see why that is. I'll just go back to the issue and see what's happening. So screen share. And here you see me. I imagine you can see me now. So I'm just going to try and share that screen again, simply because it would be so useful to do that. And let me see if I can find it. It's possible I had made a mistake with Okay, here we go. I think I know what might have gone wrong. So I'm going to try and share the screen again and see what happens with that. Hopefully you'll be able to see the screen, present to everyone. There we go. Okay, so I'm hopeful that you can see the screen now, and you'll be able to see what I'm showing. So I'll just go through that again, just to demonstrate the video itself. So here we go. You'll see the landmarking and palpating for the erector spinae on the left side, and the position of the thumbs and fingers. The thumbs are flat on the belly of the erector spinae muscle. We take slack, depth, and you'll see the challenge now. You can see I'm very deep adjacent to the muscle and able to challenge medially and then move through in the direction of the challenge. So there, that muscle would have had a very good result. We're going to look now at the next points that I wanted to raise about not being too light. So thanks, Ria. Everyone might be able to see that on the screen, that Ria has helped me find the right way to present these webinars. I actually, as you know, I've tried several different systems of presenting webinars, and right now I'm just using Google Hangout, and I think honestly it's the best. It's the cheapest, it's the freest, and it's almost the easiest. There's a few things you can't do with it, like you can't be full screen, and video is tricky to present, and presentations don't work in that either. But generally, you're hearing me okay, and you're seeing what I'm presenting, so that's wonderful. Okay, so yeah, whether you're working on the back muscles, or you're working on a shoulder, or you're working on an elbow, or the pelvic procedure, or a knee procedure, you know, really study what is the structure you're trying to stimulate with the Bowen Therapy move, and learn that. Practice it on yourself. See the range of pressures you can apply on your own body, and learn how to work the different body types that you'll come across. You know, the skinny, loose people, those skinny, tight people, those medium builds that have very little slack, along with the large build people who have also very little slack. And then the people who are much larger with a little bit of adipose tissue that you have to work through. You know, and attend a live class and practice on each other. And, you know, practice is very important, but your effort has to affect the muscle and structure that is designated in the procedures. And that will help you have the best results with clients. Never overwork the structure. You don't want to squash it. You don't want to put any pressure on it that would feel uncomfortable. But you cannot be too light. And I've had that comparison from a lot of therapists that they are too light. So another point I'd like to make about this for this webinar is that the therapy is very simple. And it seems easy until it doesn't work. And I think all of us experience this day in and day out. We have seemingly good results, and then suddenly it's not working, or what was working is no longer working, or symptoms have changed and the new symptoms don't seem to respond to the treatment choices we're making. And so it's our job to try and differentiate what is going to be effective and what isn't. So when you reach a plateau with a person, it might be in just the second visit, or it might be in the 10th visit. It doesn't matter when. It's a question of how do we read their symptoms and how do we read their response to the treatment and know what to do. So we can use a couple of cases to demonstrate this. And this is just some very typical stories that you might come across. And I've briefly described the client histories. So this lady came in a couple of years ago now, and she's a very active, healthy person as a dancer and a choreographer, in fact, and had come for a long-standing groin pain. And it was a kind of pain that was very, very deep inside the groin and extremely acute, so very much affecting the nerves and therefore neuralgic. It would refer into her thighs and especially into her knees. Her knees were a tremendous problem for her, and she was actually having intensive prolotherapy on her knees. And someone had referred her to me. I don't know exactly the story there, but anyway, she came, barely able to sit or stand, in a lot of pain. She was seeing many different therapists, and probably more than I've listed here even, and on a very regular basis. So she's not unwilling to try things to resolve this problem. And in fact, I will say very early on in the treatment, I knew what to expect for her. So going through it, I'll state what I did on the first visit. She was very acute, and despite that, I did quite a lot of treatment on this patient. So BRMs 1, 2, and 3, pelvic, sacrum, and knee procedures. And a week later, she came back, and on the second visit, she described that she had ameliorated for a few days, and then a complete and total relapse, whereby all the symptoms had returned to where they were before. So it was a good treatment. So I gave the same procedure again, and again treated the pelvis and sacrum and the knee procedures. And in my mind, I'm questioning, you know, why it didn't hold. Even after the first visit, I'm asking that question. So one of the ways to answer that is just to repeat the same thing and see what happens, to know whether it's just a question of repetition. In this situation, she came back, and again, the same complete relapse after a few days of feeling improvement. And now my question is not just whether it's a question of repetition. I don't think it's that. My next question is are other therapies interfering with the treatment? And then also my question is whether there's something actually in the way of her ability to recover. And this you'll see is a very important question. So the fourth, I did in that visit, the third visit, BRMs, I did a procedure called the psoas and also the knee procedure. The knee procedure simply because they were so inflamed, they could barely bend. And I'm not sure whether that was the result of the symptoms she had or had, oh, sorry, I got a message. We're still on the last screen. So let me go back to the settings and I see what's happening. So I need to share the screen again to the page that I'm on now. And that is, well, I'll do it here. Share and share with everyone. Okay, so right now you should be seeing the screen where I'm scrolling through a Word document. I can actually make the text bigger, so it's easier to read. So again, I'll just quickly let you see the text and the visits that I did for this patient. So basically we've done 3 visits. She's come in for now her 4th visit. After the psoas treatment, where I've done it, we can see that she ameliorated again for a few days and then relapsed. And I told her then that there's probably some pathology in the hip joint that needed to be assessed. In my mind, it's probably a tear in the cartilage of the hip joint. And it's very difficult to get that diagnosed, actually. So she needs to both see get a referral to a neurologist for her neurological referred symptoms. And I think that's what she was experiencing in her knees. And to see an orthopedic surgeon for assessment. So I never heard from her again until about a year later, and I received a call, and she told me that I'd been correct, and she had called to thank me for my care, and that I was the only practitioner that had assessed the issue correctly and referred her properly. And not to be boastful about that, but I think that the reason I was able to assume a pathology was in the way of her recovery is that Bowen therapy is so reliable that you have a high expectation of getting a response in the kind of pain-related soft tissue injuries that we commonly see, whether it is an arthritic hip joint, a meniscus injury to the knee, a bulging disc in the back, TMJ joint issue in the jaw. We see and treat these problems very, very quickly. That's what makes Bowen therapy such a useful therapy, is its efficiency. So here we had a really nice proof of that when it didn't work, I had to refer her and assume that it was something went wrong, was that something pathologically was in the way of her getting better. So that's I think a very common situation. We see that a lot in treating these issues, and don't be afraid to refer even after 2 or 3 visits where you're getting small response and it's just not holding. So when you see a good response during the session and you hear about a good response following the session that doesn't last and all the symptoms return to the same state again, you can assume there's another pathology. I'll give you another example. I saw a case this morning of a young woman. She's 21. She's come 4 times. I saw her once, and then 3 weeks later I saw her for the 2nd time, and now I saw her 3 weeks in a row. So following the 3rd visit, when she came for the 3rd visit, there really wasn't such a dramatic improvement, and I was concerned that there was something more difficult at play in her condition. And she's young, so she lives at home, and mom is paying for the visits. So I actually communicated with her mom at that point. And then I saw her today, and in fact, she's had a very good improvement between the third and fourth visit. So today, I felt very confident for her that she's moving forward with good improvement in her problems. So you have to measure how well the client is improving versus how long the treatment is lasting. So even though she's still got pain, she was able to function better. She's taking slightly less medication, and the treatment is really helping reduce the pain a significant amount. So that's solid improvement. It didn't relapse completely. Okay, here's a second case. It's a man of 58 years old. He was referred by his friend to try the treatment, and they're both doing the same sports and had similar problems, actually. So he's come for a chronic hip misalignment and the associated low back pain, which means sacrum and lumbar pain, and also neck pain. And he has a very obvious postural issue, and various other pains, including his arms and bunions, which are as a result of his sports that he does. So he's actually seeing not just a chiropractor, but an osteopath as well. And he's very invested in his therapies. He's done, I mean, things I've never heard of, and I've been doing this a long time. I mean, he knows every practitioner in town and other towns near here, like Seattle and places far afield, even in Europe. He's traveled the world looking for the best treatments and so on. So, he was also very testy in coming the first time. He had to fill out a form, and he was just really annoyed and irritable about it because my form takes a few minutes to do, and he just wanted to try the treatment, get it over with, assuming it wasn't going to work, and leave. And his main issue was that people get you to fill out the forms and they don't read them. Well, in fact, the form I use, and you might see it sometimes, is packed with information that's very useful for Bowen Therapy. It's the history of other therapies they've tried, a history of ailments and injuries, a history of other conditions and family history and so on. So there's a lot of important information. Anyway, he settled down, had the treatment, felt really nice at the end. You can see again, I've done BRMs 1, 2, 3, pelvis, sacrum, his knees, and feet. And, in his case, yeah, he needs his feet done because they're very painful. And bunions, they're not from gout or anything like that. They're really from mechanical injury. And in a way, I did the knees and feet also to give time because, the body has to process during the session, and sometimes an hour is really not enough time. So these treatments that I'm representing with these two cases are often over an hour long, maybe even an hour and a half. Okay, so he comes back a week later, great response, and I do a little bit variation on the treatment just to follow his other symptoms to see what's happening in his body. You can see I've done again pelvis and sacrum, but this time I've added the respiratory, the upper respiratory, and the TMJ. And again, I do the knees and feet. So all good stuff, Third visit, he comes back, he's never felt better. He's done really, really well. So in essence, I'm just going to do the same thing, and we did upper respiratory, TMJ, pelvis, sacrum, knees and feet. Now he comes back for the fourth visit, and this time it was a couple of weeks later. And this time he's come back with spasms happening in the middle of his back. He's very anxious about that. It's a new symptom for him. And for me, that's wonderful news. It means that his body is working differently. His musculature is behaving very, very differently now. So we can see then that there's some big changes in his body from that. When I look at him subjectively, his posture's not changed that much. His hips have aligned very, very well. His pelvis, his trochanters, the rotation of the one hip is much more correct. It's very much in balance. So his foundation is solid. But looking up his spine, he's got this huge deviation in how his neck sits in his rib cage. So you can see it with some strong deviation there. And throughout these visits, right up to the fourth visit, nothing has changed. So this time I basically do the same thing, and reason being is that we wanted to deal with the mid-back spasm. And respiratory was the right procedure for that, I think. So here we come to his fifth visit. He's got a new symptom of neck strain. And in this case, I elected to do a procedure called coccyx and neck, and again, knees and feet. And he did really, really well. So he took a month away and came back after doing some form of Tibetan massage, where he completely relapsed and went into an absolute crisis that he needed immediate treatment when he got back. So I went back to his old staple of how the procedures that went really well. So after the sixth visit, he's all recovered, and the only remaining issue is his posture. So this is the big area of discussion, and how to discern what to do next. So right now he's at a very stable place. He's doing much better. He knows not to do other massage and such. And he's really never felt this good. And in my observation, I'm looking at him and still seeing this tremendous amount of room for improvement. And when I look at his posture, I see the deviation in his neck. It literally sits askew on his neck. His shoulders are fairly even now, and the neck just deviates maybe a good inch to the left. So I ask about this and ask him about his posture and when he might have observed this for the first time. And he's a very connected person, and for him it's clear it's definitely a birth issue. He was born with forceps delivery, and I ascertain that in my mind to be probably true. That type of deviation in his spine has been there a very, very, very long time. And so there weren't really any other major traumas that would have caused that. So we both agree on that in our discussion, and we're going to assume that to be the case. I've written the word fascia, and the reason being is that with Bowen Therapy as a tool of correcting posture, we're neither manipulating the length or strength of muscles or tendons. We're not adjusting the joint alignment. Indirectly, we are, but it's through the effect on the fascia that we see the changes that happen with Bowen Therapy in the effect of muscle tone and tension, muscle symmetry. We see the joint alignment correct itself through the way the fascia is affected. Now, what we know about fascia is that it's a liquid, essentially, a gel, if you like, a sheath that surrounds every structure of our body. But that fascia is very, very malleable. It's completely able to realign itself. And I think during the pauses, when a person experiences those sensations of movement in their body, it's clear to me that that's fascia. When you as a therapist can discern change in tone and tension between the adipose tissue and the different structures of muscle and tendon, when you can see change, you're seeing the change in the fascia. This is why we need to drink a lot after the sessions, because the fascia is not impinged. It's ready to rehydrate, and that's why we get so thirsty after a Bowen therapy treatment. And in a way, I'm going to create an idea for you around fascia, that in Bowen therapy, when you reach these junctures of choosing how to proceed with a patient, such as this case here, that you're really thinking about how to mold the fascia. So fascia molding is, I think, a good term for Bowen therapy. One of the procedures that we use for that is called the scoliosis procedure. And the scoliosis procedure is an application of procedures we use very, very commonly. They are the respiratory procedure and the BRM3 moves 1, 2, 3, and 4. So the moves, I'm going to look at those now. Let me go back to where I need to change the screen I'm sharing. Getting the hang of this now, so thanks for bearing with me. And here we have the one I want to share. And we're going to see the description of the scoliosis procedure. And let me see if I can make this bigger. Great. So this is actually in the manual 5 and 6, and I believe on page 35. We see two procedures actually. They're called thoracic procedure, which essentially is chest pain, and scoliosis. This is worth reading. The thoracic procedure is a simple protocol using familiar moves. As I've just said, the moves respiratory and BRM3, the neck procedure moves. There's two ways to use this. One for chest pain, which is one-sided chest pain, left side or right side, or, and I'm not going to talk about chest pain now, or as a scoliosis technique. So the prerequisite is the respiratory procedure. Moves 1 and 2 performed on the patient, followed by a 2-minute pause. We turn the client over and we perform moves 3, 4, and 5 while holding the point below the xiphoid process as the holding point. So now we're going to look on the right-hand column and see how we use this procedure. Prerequisite, BRM2, and maybe BRM1 additionally. We perform the respiratory procedure, moves 1 to 5, as I just described. Wait 2 minutes, and we return to the patient and perform moves 1 and 3 of BRM3, or moves 2 and 4 of BRM3. So just to describe those properly, moves 1 is where it's located on the side of the neck over the posterior scalenus muscle and just in front of the trapezius muscle, move 1. We'd then be doing move 3. So we start by doing move 1, followed by move 3, which is at the top of splenius capitis and where trapezius muscle insert on the back of the occiput. So move 1, move 3, followed by move 2, and then move 4 on the right-hand side. When we see the client the following visit, we would do the opposite if there was no reason to do the same again. So in the second visit, we might likely do 2, 4, followed by 1, 3. So we might alternate. And in treating scoliosis, you may end up doing several treatments in this pattern of alternation. In my treatment of this patient, I chose to do the symptomatic side because the left side was the deviated side. His neck leaned towards the left side, so I treated the left side first, followed by the right side. And the key to knowing when to do this is that you've done the prerequisite, and it's described here under chest pain. General balancing, Bowen Therapy treatments, at least 1 week prior. And, when we talk about balancing the body, we talk about creating stability in the symptoms. So whether you're talking about the fertility management of a patient, or you're talking about the scoliosis treatment of a patient, we've created stability with those treatment plans. So it's a very, very simple idea, and I encourage you to try this with your fine-tuning of cases that have responded well but still need more therapy. Looking back at his history and understanding what may have occurred to his neck at childbirth is incredibly important. But it doesn't have to be so dramatic as forceps delivery at birth. It may have been a developmental stage of growth, for example, and coinciding with a bad flu where you were laid up for a week or more as a child in your stage of growth development. That can be enough to deviate a spine in its growth development. So these sorts of issues need to be addressed as early as possible in treating those kind of conditions. Great. So I've got a little video that I'll also show of the respiratory procedure, and we'll see how that looks.
Yeah.
Just to give you a bit more comfort around the procedure as a whole. So here, oh, this is the wrong one. I apologize. I want to share this one. Yeah. Here we go. This is the respiratory, the back moves, and then we're going to look at the neck procedure and see the respiratory procedure and see the moves that we do on the neck. So here I am aligning the moves 1, which is on the right side. We're going to be taking our position with the fingers level with the inferior margin of the scapula, so the inferior angle, the bottom corner. We have our client positioned with their head turned to the left, and we've locked their leg by bending their knee and rotating their left hip laterally so as to create a curve in their spine. So you can see my finger, the index finger, is parallel with the inferior angle of the scapula. I take slack from the midpoint depth. The slack, by the way, goes all the way to the spine. The depth, the pads of my fingers are pressed against the spine. The tips of my fingers move over the erector spinae and the iliocostalis muscles as if you're going over a washboard. And then you repeat on the same side, turn their head, switch legs, and do the opposite side. So now we're going to see the holding point. Let me just do that. You can see the bottom rib. There's the xiphoid process. There is the first place where there's no cartilage below the sternum there. Xiphoid, xiphoid, and a little bit lower than that is where we want to hold. And I go a good finger below the first spot where there's no cartilage. So in many ways, from the very tip of the xiphoid, I'm probably 1.5 fingers to 2 fingers below that. Now, there's a good amount of depth needed to engage the diaphragm, the stomach, the pyloric valve, perhaps. So we're creating a tension across the rectal sheath with that holding point. And here you can see I've located the bottom of the rib cage on the side, the lowest point of the rib, and now I'm placing my thumb midway between the holding point and the lowest part of the rib on the side. The thumb is adjacent to the bottom margin of the ribs. I take skin slack toward the holding point, and then depth, lots of depth. So I'm pressing down now while the client is exhaled to move the thumb obliquely over the muscles rectus abdominis. Okay, so we do then move. That's another way of landmarking, is to find the midpoint in the clavicle over here, and we can then see a landmark that way. Okay, so that's move 3, and then move 4, I use my middle finger because it's able to position itself flat like the thumb is when I reach across. Thumb is kind of awkward, so I use my middle finger there. Find the midpoint between the bottom rib on the right-hand side and the holding point. The fingers touching the edge of the rib cage, slack along the edge, depth, and an oblique move along the edge with the side of the finger, the edge of the rib cage, and then the palm of the finger is on the rectus abdominis muscle. Great. Move 5, we take away our holding point 3A and take skin from below the holding point superiorly upward, and then press down, following the breathing of the patient. When they're fully exhaled, we make a downward move. So after that, we can now do a I'm going to show the video of the procedure in a sitting position for BRMs. This is actually a video of BRM 3. So I want you to remember that we're doing the procedure in a different order when we do the scoliosis. So this is move 1 in this position, and then we'd be doing move, here we can see move 3. This is how you can landmark. At the level of the top of the ears, if we run our fingers all the way back, we come to a bump in the head called the occipital protuberance. So it is the most prominent bump of bone on the back of the skull. And we're just going to find then the insertion of the trapezius and splenius capitis tendons and make a medial move. So if I was doing the scoliosis procedure, I would have done move 1 and followed by move 3, and then move 2 followed by move 4. And I would do it in a lying down position, but this is just to show where those moves are made because you can't see it when it's lying down. Okay, so that's really the information I wanted to share. I know I've rambled a bit and had a little bit of an awkward start to the webinar. So I hope you've enjoyed it. I would open up any, you can chat actually. I think it's possible to do that. If anyone has any questions, or in the Q&A, there's a question. Oh, I see everyone's been commenting. I'm so sorry. I didn't get to see these. So Susanna was very kind to comment on the videos. And I just want to see if anyone else wants to make any comments about this before I call it a day. I hope you enjoyed the ideas I've shared with the treatment and use of Bowen therapy, and understanding a little more about what are the limits of the therapy and how you can really take a patient much further than just pain relief. So thank you so much. I'll just give it another second and see if anyone else wants to make a comment. And thank you again for bearing with me, and take good care, and I'll do better next time with the technical part. Thanks a lot. Bye-bye.